Welcome back to the Health Chat. I'm Dr. Greg Eckel.
And I'm Dr. Greg Nye.
And today's topic is an interesting one. We are talking about men's health. And you may ask yourself, I've asked myself, why men's health?
Why men's health?
What's
so
different?
Unique?
What's different about men's health?
Right.
And you know, one of the things, or there's a few things. Heart disease definitely is the #1 killer, but it's not unique to men. Women have gained.
It's the #1 for women too.
Yes,
so
they've gained on the men on heart disease.
Equality.
It's equality. There it is. So that's not really unique. We are going to touch on that. But the other big components of what we find when you look at, I actually just had a patient yesterday comment, mainly women come to your office. And I said, actually, across the board, it's about a 70% more women in our practice, and I think across the medical spectrum. Not that women have more health issues, but that women actually are proactive and they actually will want to investigate what's wrong with them, versus men who
tend to ignore
what's wrong with them, right, on multiple fronts. And so it's, men kind of get stuck into that man box of, oh, it doesn't bug me, it's not bad enough, it's going to go away. It's going to go away.
Yeah, denial.
Denial is, I guess you would call that denial. And also men tend to drink more and smoke more, which are two huge contributors into a wide array of health issues. So today we're gonna talk about just, in the conventional realm, they're really looking at two separate conditions. In particular with the prostate and the colon and screening for cancers. So we're going to talk about that, and then we'll get into some of the heart disease component, and then what our general approach is with men and the unique component of naturopathic care.
Good. So in the conventional world and thinking about men's health, like that topic of men's health, it's sort of defined, the issues that are most relevant to men are prostate cancer, because very few women have prostate cancer, actually, and colorectal cancer, because that is affects men more significantly than it does women, although certainly it's a issue for women as well. And there's sort of a growing recognition of this kind of the male equivalent of menopause, which is referred to as andropause. And so there is some recognition of that, although I don't think that is necessarily widespread in the conventional world. In our world, there's more of a recognition of some of the changes that are happening there and how we can impact those. So today we'll kind of run through, and we'll start with the cancer issue. So in the conventional world, one of the primary drives around the whole program of men's health is to get men screened for cancer. In particular, prostate cancer and colorectal cancer.
Preventative medicine.
Preventative medicine. Yeah, that's
early to drug.
Early, yeah. You detect it early so that you can apply various kinds of drugs. So the first thing that I think we want to say about especially prostate cancer, because I think this is probably this is the one that is really marketed to men, and it's almost exclusively reliant on a blood test.
Right, one test.
A PSA.
Right.
Prostate specific antigen. And the tragedy of the use of this marker as a screen for prostate cancer is that it's a terrible marker. And in fact,
it is the only one we have, though.
It's the only one we have.
Yeah.
But what happens is that men get screened, they get the blood test done for PSA. Some percent of them is found to be elevated, and there's sort of this streamline right into the next step, which is a biopsy.
Right. Well, and when you hear, okay, you got your doctor, they do the blood test, and they say, well, you may have cancer. We need to now do a biopsy.
Right.
Everyone says, yeah, you just said cancer to me. I want to know.
Right.
Right? It's and they've done the research on this, on the marker, and they show the pain and suffering of that statement, you may have cancer, creates way more anxiety and stress.
right,
than
and maybe cancer,
right. than anything else that happened. And so the intervention in itself is traumatic.
Right.
And we have seen countless men that have come in right either in the beginning of that process or have been through 3 or 4 biopsies of their prostate, which is not a benign process.
Right.
You're getting 8 to 27 holes bored into your prostate, which is about the size of a walnut. And it's pretty sensitive tissue, to find, oh, well, there's no cancer there. So the biopsy in itself can spread cancer and creates inflammation and injures the gland.
And on top of all this is there's a growing body of research that shows that PSA is a very unreliable marker for prostate cancer. Essentially what a PSA tells you is the size of the prostate. And so anytime a prostate is enlarged, it's more apt that will be reflected as an elevation in the PSA. And so using just the PSA as a marker for prostate cancer, it's a very, very unreliable screen. There is an additional test that can be used. So there's a total PSA and then there's a free PSA. And it doesn't matter what the details of those two are. But you can get a little more specific or a little more accurate with the tests if you do both of them and you kind of use the combined info from the two tests. And really what you have to do is do those, you do them once and then you do them again some months later to see how those two are changing.
And you wind up playing a percentages game.
Right,
It's all on percentages. The other big one, though, around prostate that we've found is vitamin D. You've heard us talk countless times about vitamin D, but it's a great prognosis marker, meaning if you have adequate amount of vitamin D, the chances of the PSA, and if you do have cancer, of it being aggressive or being an issue are much lower if you have adequate vitamin D. So I think I said that clearly. But
yeah, I think the more vitamin D, the less risk of prostate cancer.
Right.
Either being there, and if it's there, of it growing. Yeah. So once again, another type of cancer that vitamin D is very important.
So take home, I guess, on prostate screening and prostate cancer is we take a watch and wait approach, which is you get a measurement. You still have to do, we still run those tests. It's the only marker we have. It's a poor marker, but it's not all we got.
Well, we'll talk about some other. About some other
cancer screening.
Cancer screenings. Right. We're still doing PSA. Right. It's not that we don't use it. It's just that we would never rely on it exclusively.
Right.
Then with colorectal cancer, that is then the emphasis to get people in to get colonoscopy.
Yep.
Sigmoidoscopy, colonoscopy, to just look and see if you can find polyps or actual, growth of any kind of tumors inside the colon that then need to be taken care of. And I don't, I certainly wouldn't argue against colonoscopy. I think those are valuable techniques to use with colon cancer. What I think I would add on to all of this discussion about detecting a cancer is that, in fact, there are a number of other tests that can be utilized that have a good deal of research behind them that are specific for these kind of cancers that we're talking about, that can give people much more information,
more clarity,
in which to make a decision about, all right, do I need to go ahead with a biopsy, or is this something that we can hang out and see what happens with these markers? And so, just to run through a few in particular.
Sure.
I think probably the one that has the most widespread application with all these kinds of cancer is it uses what's called fibrinogen degradation products.
Say that 5 times real fast.